This lesson is on Strongyloidiasis, which is a gastrointestinal condition caused by infection by a parasitic nematode, which is a roundworm. So it's not only a gastrointestinal infection, but it can be a multi-system infection. We'll talk about this when we discuss the signs and symptoms later. So again, Strongyloidiasis is due to infection with Strongyloides species. Again, these are those parasitic nematodes, those parasitic roundworms. And Strongyloides stercoralis is the most common species that causes infection. Another important species that causes infection is Strongyloides fuelliborni or fuelliborni. There are other species, but these are the two most important ones. And these Strongyloides worms are also known as threadworms. Now, the prevalence of infection by this particular organism is likely underestimated. Some global estimates place it at 7 to 9% of the global population being infected by this particular worm. Oftentimes, infection is undiagnosed or undetected because oftentimes patients may not even be aware that they're infected. They are asymptomatic, meaning that they have no symptoms. And in other places in the world, we can see even higher prevalence rates. So this particular parasitic nematode is found worldwide in all continents except Antarctica. And in certain parts of the world, we see even more infections by this particular organism. We also see higher rates of infection in individuals who have experienced confinement or institutionalization, especially prisoners of war in the past who were confined in Southeast Asia. And in particular parts of the world, we see even higher rates of infection. Some of these include East Mediterranean locations. So these locations have some of the highest reported prevalences of strongyloidiasis. Up to 40% of individuals in those areas have been reported to have infection with this organism. The tropics and subtropics also have a higher rate, so anywhere from 10% up to 40%. And Southeast Asian countries are also at a higher risk of having these strongyloides infections. Now let's talk about the pathophysiology of infection by these nematodes. These Strongyloides nematodes have two life cycles. One life cycle is a free-living life cycle, where they are in the form of a rhabdiform larvae, and the second life cycle is a parasitic life cycle, where they are in the form of a falciform infective larvae. So those are the two life cycles. Now let's talk in more detail how they cause infection. So if there is a host, a human being who is infected with these particular nematodes, or another host like a dog, dogs also serve as definitive hosts for this particular parasite. When there is a host for these organisms, they excrete the rhabdiform larvae in their stool. That stool and that rhabdiform larvae will enter into the environment, and the rhabdiform larvae will develop into free-living adults, and they will live in the soil. So rhabdiform larvae is excreted, it forms into a free-living adult worm, and then they will produce eggs. And the eggs will be produced, more rhabdiform larvae will hatch from the larvae and will develop into what we call the falciform larvae. So falciform larvae will be developed, and those falciform larvae will be in the soil. And if someone or an animal like a dog walks along and steps on or touches those falciform larvae can penetrate into the skin. So the falciform larvae penetrate into the skin of the patient, and then they become infected with the falciform larvae. The larvae migrate to the intestines and mature. So they enter into the skin, they migrate in through the bloodstream into the small intestine, and they mature into an adult. They then produce eggs. They deposit the eggs within the intestinal mucosa. Then the eggs hatch and become rhabdiform larvae, which are then excreted in the soil, and the cycle continues. And there's also one other thing I want to mention here, and that is autoinfection. So autoinfection can occur when these eggs hatch into rhabdiform larvae, and the rhabdiform larvae is in the large intestine of the patient, and the rhabdiform larvae then form into falciform larvae and then start the cycle again inside the patient. So that is autoinfection. So again, rhabdiform larvae form into falciform larvae within the patient, and the falciform larvae lay more eggs, and the cycle can continue inside the patient. Autoinfection likely occurs at small levels in immunocompetent patients, but this is going to be a problem when we look at immunosuppressed patients, and this is going to cause some very severe complications, which we will talk about later on in this lesson. And also another important point to make note of here is that penetration through the skin, or the transcutaneous route, is going to be the most common way that this organism can infect patients, but that's not the only way. There are other ways that this worm can infect patients. Some of them include through fecal oral transmission. So if there's contaminated water, for instance, they can ingest that, and that can be a way for this worm to infect individuals, and also through organ transplants. So in some patients, if they've had disseminated disease, worms are within the organs and there's an organ transplant, that's also another way of transmitting this, but that's going to be a rare way. The transcutaneous way is going to be the most common way that this infection occurs. So once the patient is in contact with the falciform larvae and it enters into the skin, there's larval invasion. The parasite can enter into the skin and into the dermatological system. So it penetrates into the skin. It can cause multiple signs and symptoms within the skin, which we will talk about here in a moment. The larvae will then try to enter into their target system of the body, which is the gastrointestinal system, especially the small intestine. So that will cause gastrointestinal symptoms. And in some cases, they can migrate to the respiratory system and enter into pulmonary arteries, vessels, and lymphatics of the pulmonary system. And that can cause a variety of signs and symptoms, which we'll discuss also in the upcoming slides. Now, we did mention this briefly before, but even if a patient is infected, they may be asymptomatic, meaning that they don't show any symptoms at all. This would be asymptomatic carriage. This is going to be a common occurrence in a lot of patients. And the symptoms of infection are so varied that in some patients, they are asymptomatic, but in other patients, it's life-threatening infections. Again, oftentimes it's going to be due to immunosuppression. We'll discuss this later on. So in asymptomatic carriage, there's no signs or symptoms. Some patients may have mild or moderate symptoms. We'll discuss those here in a moment. And if there is asymptomatic carriage, the nematodes can live and replicate within an immunocompetent host for decades undetected. Now, on the other end of the spectrum of signs and symptoms, we have the life-threatening infections. We'll discuss these later on in more detail. They are the disseminated infection and hyperinfection syndrome. These lead to severe symptoms, and it can be life-threatening. Again, this is going to occur in immunocompromised hosts. And again, what we mentioned is the hyperinfection syndrome and disseminated strongyloidiasis. Now let's talk about the clinical features in immunocompetent hosts. Again, we can have significant numbers of these patients being asymptomatic, meaning that they have no symptoms or signs at all. 50% of patients are going to be asymptomatic. And the other 50% are going to have a variety of varied signs and symptoms. So we are going to break the infection down into acute strongyloidiasis and chronic strongyloidiasis. So acute strongyloidiasis is going to occur early on. So when a patient is exposed to these nematodes, they experience signs and symptoms. That's going to be the acute phase. And then chronic is going to be later. So acute strongyloidiasis is often going to begin with, again, those parasites penetrating the skin. It's going to lead to the parasites migrating through the skin and leading to particular dermatological findings. And it can lead to what we call cutaneous strongyloidiasis and something more specifically called larvicurans. And larvicurans is going to look like this. It's going to be this serpiginous rash. So it's erythematous, raised, serpiginous. Serpiginous simply means that it looks like a serpent. So it's actually the worm under the skin. It's going to be very, very itchy for patients. And often is going to be an allergic reaction to the worm within the skin tissue. And the worm is going to migrate through the skin. It can migrate very rapidly, anywhere from 5 to 15 centimeters per hour in some cases. Now, not all patients will have larvicurans. It is estimated that 30 to 90% of patients with strongyloidiasis will have larvicurans. So even if some patients may have a parasite penetrate the skin, they may not have this particular sign or symptom. So that's also important to make note of as well. When there are dermatological findings, though, these include a urticarial rash. It's often termed as a ground rash. Most of the time, we're going to see it on the feet. People are walking on a beach, for instance. They have this parasite penetrate through their skin. Their feet are going to be very itchy. That's going to be often a very common location for this particular rash to occur. The rash is going to be intensely pruritic, meaning that it's going to be intensely itchy. The itch can last for up to 3 weeks. It's going to be papulovesicular, meaning that it's going to be a mix of papules and vesicles. Papules are raised skin lesions less than 10 millimeters in diameter. And vesicles are going to be less than 10 millimeters in diameter, but they're going to be fluid-filled. So those are the dermatological findings. And moving on now to the gastrointestinal system, once the organisms have made it to the gastrointestinal system, they cause a variety of signs and symptoms. These include watery diarrhea. Watery diarrhea is often going to be profuse or excessive. It's going to be mucoid as well, so it's going to be some mucus in the diarrhea as well. There can also be abdominal pain, especially crampy abdominal pain in the epigastric area, so the area above the belly button. We can also see nausea and vomiting occurring as well. Weight loss can also occur. Malabsorption can occur, so individuals may have issues with absorbing fats, so they can have steatorrhea. They can have issues with absorbing vitamin B12 and some other nutrients as well, so this can cause weight loss. Some patients can also experience pruritus ani, which is an itchy anal area, and they can also experience bloating as well. And if there's infection in children, it can lead to malnourishment. And malnourished children with this infection can often have chronic diarrhea, cachexia, and can have failure to thrive. Those are some important signs and symptoms of infection in children. And in the respiratory system can be affected in some patients as well. And if the respiratory system is affected, it's known as symptomatic pulmonary strongyloidiasis. It's going to occur only in a minority of patients. Only around 10% of patients will have respiratory findings. These include a cough. The cough's often going to be non-productive, meaning that's going to be a dry cough. In some cases, though, it can be a productive cough, and they can cough up some phlegm or mucus with some blood streaks in it, so there can be minimal blood streaking in the mucus. This is going to be due to those worms being in pulmonary vessels and some of the vessels breaking, causing some bleeding. We can also see dyspnea or shortness of breath, wheezing, and fever in some patients. Some other clinical findings of symptomatic pulmonary strongyloidiasis includes eosinophilia, high level of eosinophils, and this can lead to a Loeffler-like syndrome. Pneumonitis can also occur, so inflammation of the lungs, and migratory pulmonary infiltrates can also occur. We'll talk about some of these clinical findings on imaging when we talk about the diagnosis later. And all these symptoms we talked about can occur acutely. They can be part of acute strongyloidiasis that occurs in immunocompetent patients. So these symptoms can occur a short time after being exposed to the organism. But in some patients, though, they can have chronic strongyloidiasis. Chronic strongyloidiasis is going to essentially be the symptoms we talked about before, perhaps at a more mild severity. And it occurs where signs and symptoms occur for many years. So signs and symptoms occur for many months up to years. And chronic strongyloidiasis is often going to involve some amounts of autoinfection. So as old organisms die, they're replaced by some new ones. And this continues to occur over many years. Often the parasite load is going to be lower, but it still causes some signs and symptoms. Now let's talk about the clinical features in immunocompromised patients. So these are where we're going to have some very severe and significant complications and some oftentimes life-threatening complications. So some of the signs and symptoms we're going to talk about here in a moment may occur abruptly or have an insidious onset. So they can occur very suddenly or they can slowly occur. And the complications, the severe infections that occur in immunocompromised patients is termed as disseminated strongyloidiasis or hyperinfection syndrome. And as its name implies, hyperinfection syndrome or disseminated strongyloidiasis is going to involve very excessive amounts of autoinfection within the patient. And the number of organisms multiplies rapidly, and these organisms start to spread into other areas of the body. It's disseminated, and they enter into other organ systems, causing many other issues, which we'll discuss here in a moment. Again, this is a life-threatening condition with a mortality rate anywhere from 60 to 85%. So very, very high rates of mortality in these patients. Now, although the organisms can spread around into different parts of the body, most of the time they're going to stay in the systems we've talked about before, the gastrointestinal, dermatological, and respiratory systems. So oftentimes disseminated strongyloidiasis is going to involve severe presentations of the signs and symptoms we just mentioned in the gastrointestinal system, respiratory system, and dermatological system. Now, in disseminated strongyloidiasis, fever is always present. And we can have bacteremia and septicemia. The reason that we can have bacteremia and septicemia is because there is so much damage from these organisms in the gastrointestinal system. There can be damage to the gastrointestinal lining, allowing bacteria to exit out of the gastrointestinal system and enter into the blood. Some important bacterial species that do this include E. coli and Klebsiella. These can often cause bacteremia and septicemia of the patient. We can also see hyponatremia in these patients, low sodium levels. We can also have more severe respiratory manifestations, including hemoptysis. So that's coughing up blood. It's essentially where many, many organisms are in the pulmonary vessels and they're breaking those blood vessels and leading to a lot of bleeding within the lungs. The patient coughs it up, it's blood. So it's going to be hemoptysis. There can be pulmonary effusions. They can have pleuritic chest pain, which means that when they take deep breaths, they can have pain, sharp pain. Severe dyspnea, so they can have very difficult time breathing, and in some cases, acute respiratory distress syndrome or ARDS. And the severe gastrointestinal manifestations include ileus, small bowel dilation, strictures, ulcerations, and severe gastrointestinal bleeding where they can have bloody diarrhea. And they can also have some dermatological signs and symptoms as well as essentially what we discussed before, itching. We can see larvicurins occurring in these patients as well. So it's essentially these signs and symptoms we discussed before, but with worsening severity. And there are particular risk factors for having severe strongyloidiasis. So again, it's all about immunosuppression. Anything that's going to cause immunosuppression is going to increase the risk for having severe strongyloidiasis, or that disseminated strongyloidiasis we just mentioned. These include corticosteroid therapy and other immunosuppressives, diabetes mellitus, so having diabetes is going to increase the risk, having human immunodeficiency virus or AIDS, having chronic kidney disease, being elderly, this is going to be an important risk factor. Some patients will carry these organisms with them for decades, and when they get older into their elderly years, they can have a severe presentation of this condition. So that's important to point out. Having a malignancy, chronic alcohol consumption is also another risk factor, and having human T-cell leukemia virus type 1 infection. All of these are going to increase the risk for having severe or disseminated strongyloidiasis due to their ability to cause immunosuppression. Now let's discuss the diagnosis of this condition. How do clinicians and healthcare providers diagnose this condition? So before we talk about diagnosis, it's important to assess for risk factors. So especially important to assess for risk factors for having this condition in patients who are going to start immunosuppressive treatment, because in some patients, when they start immunosuppressive treatment, that can lead to hyperinfection syndrome, that can lead to a excessive autoinfection cycle within the patient. And it's important to assess these risk factors even if they have been exposed decades earlier. Again, some patients may carry these organisms with them for decades. So when they get older, if they start immunosuppressive treatments, if they are elderly or they have some other condition like malignancy or diabetes, this can increase the risk for having severe strongyloidiasis. So assess for those risk factors we talked about before. And if they have those risk factors, test the patients. And if they have the organism, eradicate it before initiating immunosuppressives. So in order to diagnose this condition, often we're going to require stool, ova, and parasites. The ova are not going to be found. Often it's going to be the parasites already in their rhabditiform larvae form. So we can see parasites found in stool, usually at least 1 month after initial skin infection. So it's not going to be right away. It's going to take some time before we can start to see parasites in the stool. And it's often going to require several stool samples. These organisms can be difficult to detect. Usually only up to 50 organisms can be excreted per day. So very small amounts of organisms can be excreted. So oftentimes it's going to be difficult to detect. We're going to have several stool samples needed. So at least 3 consecutive days to assess for these organisms. Testing multiple times is going to be especially important in chronic strongyloidiasis because they are even going to have less parasitic load. So it's going to be even harder to detect organisms in those patients. Blood work can also be utilized as well. Some patients can have eosinophilia, high levels of eosinophils in the blood, so greater than 600 per ml. This is often going to be in the acute infection stage, but not present in severe and immunocompromised cases. And some patients can also have anemia, thrombocytopenia, low platelet count, and elevated PT, PTT, and INR. Some other ways to diagnose this is through ELISA. PCR can also be used. Imaging can be important in some patients, especially if they have pulmonary involvement. So chest x-ray, we may see patchy alveolar infiltrates, segmental or diffuse infiltrates, pleural effusion, bronchopneumonia. A CT scan can be used as well. And then some other ways to diagnose this include endoscopy, entero test or strain test, lumbar puncture, skin biopsy, and body fluid analysis. This will be more important in the disseminated strongyloidiasis. Once a healthcare provider has made the diagnosis, how do they treat it? So this parasitic nematode is notoriously difficult to eradicate. Oftentimes it's going to require treatments and then assessments later to see if it has been eradicated and may require multiple treatments in the future. It's important to treat all cases, including asymptomatic cases, because of the possibility of having some immunosuppression later on in the future, which can lead to disseminated or severe strongyloidiasis. So some of the treatments involved include the following. Pharmacological treatments. So pharmacological treatments involve us removing or tapering pre-existent immunosuppressive agents. This is again going to reduce the risk of having severe or disseminated strongyloidiasis, which has a very high mortality rate. The treatment for this particular organism is ivermectin. That is going to be at a dose of 200 micrograms per kilogram PO for 1 to 2 days. So by mouth, 1 to 2 days. Alternatively, we can use albendazole, 400 micrograms PO, BID. So PO means by mouth. BID is twice a day for 7 days. In the case of hyperinfection and disseminated infection, we are going to use often again ivermectin, 200 micrograms per kilogram, PO daily until stool or salivary samples are negative for 2 weeks. So we continue treatment until samples are negative for 2 weeks. So it can be a very long period of time with treatment. Along with the ivermectin, we're going to add broad spectrum antibiotics because we're going to often see gram-negative bacteremia due to E. coli, for instance, as we mentioned before. And again, we need at least 14 days of treatment in disseminated strongyloidiasis. These, again, are going to be severe cases. We're going to require intensive care in hyperinfection and disseminated strongyloidiasis. It's also important to treat concurrent infections, as we mentioned before, and stool examinations are important after treatment. So this is going to be important because, again, we talked about the fact that it can be difficult to eradicate this particular organism. So after treatment, we often are going to have to test stool samples at 6 months and 12 months post-treatment to see whether or not there are any organisms left. So because of that autoinfection cycle, it can be difficult to eradicate all organisms. Even if only a minimal amount are going through autoinfection cycle, we may not get all the organisms with our treatment, so it can be difficult, again, to get rid of them. And it's also important to talk about prevention. So prevention of infection can occur by wearing protective footwear in endemic areas, especially walking on the beach or on soil, because the soil or the beach can be contaminated with these organisms, so it's important to wear protective footwear. In these areas, it's also better to have improved sanitation and hygiene, so cleaning up the beach, for instance, or the soil, making sure that there are no fecal matter or no fecal material from dogs or humans, and then close monitoring and evaluation of individuals from high prevalence areas is also going to be important. If individuals have traveled, it can be important to assess and evaluate those patients. If some individuals have lived in endemic areas for long periods of time, it can be important to assess and monitor those patients. So those are some of the ways to prevent either getting infected or reduce the risk of having severe complications later in the future. Please check out my lesson on pinworm infections. And if you haven't already, please like and subscribe for more lessons like this one. And as always, thanks so much for watching. Hope to see you next time.